Dr. Rakesh Kaul is working as a senior consultant Department of Surgical Oncology in the prestigious Institute of Sir Gangaram Hospital, New Delhi. He has done MS General Surgery and DNT Surgical Oncology, and his experience is more than 22 years in surgical oncology. He has had a vast experience of doing breast cancer surgeries in Delhi. So now I will request Dr. Kaul to begin the talk.
Thank you, Sunila ma'am and Madam Ashwani ma'am, giving me the opportunity to proceed with this forum. And I will be presenting my slides, the PowerPoint, which will be regarding the multidisciplinary approach to the detection and diagnosis of the breast cancer in the early phases of when it is detected. So, multidisciplinary approach to the early detection of breast cancer. The breast cancer is the early detection requires a very, very careful and close coordination between a clinician. It can be a surgeon, it can be a physician, it can be a radiotherapist, it can be a medical oncologist, or it can be any general surgeon, or it can be it can be the coordination is between a clinician, a radiologist, and a pathologist. These three are very important ingredients where we have to first evaluate the patient and take him to the point where he needs the treatment. I will be keeping in the view the sanctity of the limited time that is at my disposal. I will carry this presentation up to the point where the patient will be needing the treatment. So breast cancer can be detected by evaluating. The patient comes with a breast detected, she has detected it herself incidentally. Many patients come like this, or it is detected by a clinical examination by a clinical clinician, or the patient presents to us with a nipple discharge, which is blood stain, or the patient presents to the radiology department or to the clinician for the purpose of screening. On screening mammography, we detect it. And most of the times, the clinician is the first stop where the patient lands, and then he is the person who then evaluates it further. Now, once the patient has reached the clinician, what should a clinician do? First of all, take a detailed history. What does that include? Age and sex of the patient, premenopausal or postmenopausal the status of the patient. Take a detailed history regarding the breast lump. So, and the nipple, if there is nipple discharge or inversion or mastalgia, any of these factors ought to be taken into account. Just a third-year student, MBBS student. History of the risk factors of the breast cancer, which include the familial or the breast or genitourinary malignancies, they are to be taken into account. History of comorbidities or any previous history of surgery that may have an influence in the further treatment of the patient. These are some of the risk factors that I have a tabulated form, and you can see the low risk and high risk patients, especially in relation to the BRCA1, BRCA2 genes, or the family history, not the genetic one, but the familial history of the mother having, the sister having, and you can see they are all high risk and the relative risk of the patient having the breast cancer when these things are in their family. After the history comes the very important the clinical examination, which includes the inspection and palpation, which should be done. The patient supine in upright position with the arms relaxed by the side of the patient, the arms lifted up, and the third time, the arms pressed on the hips and pressed. And we have to examine also the regional lymph nodes in the axilla, supraclavicular fossa, and the neck. And if we find these nodes in these regions, the axilla or the supraclavicular, we have to note their number, whether matted or discrete, because that upstage or downstage is the tumor, and their consistency, whether they are fixed or mobile. All these findings should be documented in a paper, on a file, in a diagrammatically, in a clock system. We present the breast like a clock, and we present those symptoms, these findings. Clinical examination will include a general physical examination and the local examination, which should be always bilateral and include the bilateral. Even if the patient is afflicted on one side, the other side should also be examined in detail. And the breast, I will not go in detail, everybody will be knowing it. We look for the breast lump, what should we look there, the shape, size, mobility, and for the nipple dish, whether it is unilateral or bilateral. Most of these, and I will proceed further. And these are the methods of palpation. The patient's sitting upright, arms lifted by the side of the hips and breast, the palpation of the axilla, bimanual palpation. And these are the methods of palpation where it is the radial approach. This is the lawnmower approach, because by these methods, and this is the concentric approach, the main purpose of these approaches is that no quadrant of the breast examination is missed. And you will be surprised to know that physical examination cannot always distinguish between benign and malignant masses. But however, in experts' hands, the studies have shown that the malignant breast lumps in symptomatic women could be detected up to 73 to 93% of the times by the experienced surgeons or clinicians. Diagnostic evaluation, first of all, it will be the bilateral mammography, which could be preferably tomosynthesis or 3D mammography. And if the patient can present without symptoms for screening, or if there is any symptom, they can present with for diagnostic mammography. And if suspicion, and I will tell you a few of the slides I will be skipping, because the coming speakers will be speaking about that in detail. So I will not be wasting that time. And diagnostic mammography, if suspicious, then other view spots are taken, like compression spot or magnification waves we are taken. Mammographic features are the soft tissue masses or microcalcifications. And soft tissue masses, most common is the spiculated mass, which is present in 90% of the invasive cancers. And microcalcifications are seen in 60% of the cancers, which represent the necrotic cells in the center of cluster of tumor cells. It is both in situ tumors as well as invasive tumors. And these are the spiculated lesions, these are the microcalcifications, and here also the microcalcifications. So clinical examination followed by radiological examination and also the breast ultrasound. In fact, the breast ultrasound should always complement the digital X-ray mammography. Its uses are to characterize and localize the mammographically detected masses, identify cystic masses. For ultrasound guided biopsy, we can place a clip, ultrasound guided clip, in a locally advanced tumor, so that after NACT, neoadjuvant chemotherapy, if the patient prefers breast conservation surgery, the clip can be helpful in detecting the site of the lesion. And in fact, it can identify 10% of the breast masses which are missed on the digital mammograph. Sonomammogram only is preferred option in patients less than 30 years of age, because benign lesions like cysts are not usually visualized on the mammogram. Incidence of carcinoma in breast cancer in young is less than 1%, though in these times we are finding it more and more in the younger people, and theoretical risk of radiation is there. This is a diagnostic algorithm. When we say that we have discussed in detail, I will not go into it, because there is a palpable mass in the patient under breath, then what should we do? After the radiological examination, which means the X-ray and the ultrasound, we summarize the patients in the final diagnostic assessment categories, which indicate that is the BIRAT, breast imaging reporting and data systems, which we categorize as BIRAT 1, 2, 3, 4. The higher the BIRAT is, the higher the chances of the malignancy become. So whenever a patient biopsy is sent to the pathologist, and it is mentioned the BIRAT 4, BIRAT 5, it should raise the pathologist should be very, very careful that the clinical examination had revealed very high chances of malignancy and nothing should be missed. Then there is an MR mammogram, axillary lymph node. What are the indications? Axillary lymph nodes. There is an occult axillary lymph node, but the breast tumor is not seen. That is the occult. We go for MRI. Paget's disease with negative physical examination for finding out any mass in the breast. Clinically and mammographically indeterminate newly diagnosed breast cancers for them. For posterior extension of the tumor into pectoris major muscle, minor muscle, or the chest wall, for which X-ray or the ultrasound is not a useful investigation. For locally advanced breast cancers to assess the response of the neoadjuvant hormonal or chemotherapy. For patients, for example, those who are having genetic problem or it is running in hereditary, is a BRCA1, BRCA2, we can have those as a regular mode of screening. For patients who are having bilateral or planning bilateral breast reconstruction surgery, the MRI is indicated in them. Even though, I should add, even though MR mammogram has been used extensively for the last 2 decades, there exists no sufficient data that shows that it improves the overall outcome of the patient. And moreover, on the contrary, it leads to unnecessary surgeries, delays treatment, and may lead, in fact, to over-treatment, which is not necessary. Then after we have done the radiological examination, the next comes the breast biopsy. It should be very importantly stressed upon that the breast biopsy should always follow the radiological evaluation, not vice versa. And the goals of the biopsy is to obtain the sufficient diagnostic material used by the least invasive approach. Suspicious mammographically, which should be biopsied? Which lesion should be biopsied? BIRAD 4 and BIRAD 5. Only exception is BIRAD 4A, for whom 6-monthly follow-up may be recommended depending upon the suspicion for DCIS or invasive. And clinically suspicious palpable breast masses, they should undergo breast biopsy. Preoperatively, histological confirmation permits better multidisciplinary treatment. And treatment decisions regarding should we go for upfront surgery, should we go for upfront chemotherapy, while whether we should perform breast conservation surgery or MRM, sentinel lymph node biopsy should be done, or whole axillary lymph node dissection should be done. So this comes very well. It is very helpful and handy when we perform the preoperative histological confirmation. And I think Dr. Shelley will be discussing the details of the biopsy approaches and methods. I will be skipping this. Once all the biopsies have been taken, they should be sent to the pathologist and with the documentation of the patient's name and MRD, the margin orientation, the documented where from this biopsy has been, which quadrant, and whether there is any previous reference to the biopsy. It should preferably and always should be mentioned there. Besides histopathological examination and diagnosis, assays for receptor status like ER, PR, HER2, as well as multigene assays are important for determining the further systematic treatment strategies. When to do the rebiopsy? When there is discordant pathological and radiological findings. And on radiology, we find very, very suspicious, and on pathology, we do not find anything. We should repeat the biopsy. When the core needle biopsy or FNAC is malignant, but material obtained is so insufficient that we cannot perform the further IHC analysis. If core needle biopsy is suggestive of the atypical ductal hyperplasia, LCS, or a complex sclerosing lesion, a repeat biopsy is preferred, as sometimes they may be associated with the malignancies. Histopathology, it can be benign or malignant. 90% of the, I think our pathologists will be discussing in detail. We can find the non-proliferative lesions among the benign, proliferative with atypia, proliferative with lesions, and I will be skipping all those. But these are the malignant lesions that we mostly encounter. The IDC, ILC, mixed, DCIS, LCIS, malignant phyllodes, even we have seen breast sarcomas once a while. The base of them, we come to after we have assessed, we have biopsied the patient, we have biopsied the lump, and we have come to know that it is the cancer, it is the malignancy. It comes the clinical staging. And for clinical staging, first of all, we can do the bone scan, especially those with localized bone pains and increased serum alkaline phosphatase. Small lesions with normal alkaline phosphatase levels, the studies are that we can ignore bone biopsy. CT chest, if there are chest complaints, or X-ray chest will do without that. CT scan whole abdomen, including pelvis, especially if there are abnormal LFT findings or abnormal abdominal or pelvic examination is present. There are some symptoms, there are lump, there are anything. Otherwise, ultrasound whole abdomen will do. All the above mentioned investigations can be replaced by PET-CT, but it is not desirable in the early stages. When it is stage 1, it is stage 2. It is usually desirable in inoperable stage 3 and beyond that. For the breast cancer in non-operable stage 3 and above, that is what I have said. All the above mentioned investigations can be skipped in favor of PET-CT scan, which is desirable. NCCN approach based on many studies have also shown that extensive imaging yielded little for the patient with newly diagnosed cancer. So we should proceed ideally with the basic investigations if the patient is asymptomatic. And if it is LABC or he is symptomatic, then we should upstage the investigative armamentarium. After clinically assessing the patient, the disease of the patient, and we determine the clinical stage. And for that, it is very important because we are going to treat the patient. We have taken the patient to the point where now he needs a treatment. We have to do the clinical staging. And for clinical staging, we have to know whether it is stage 1, 2, that is the early breast cancer, or inoperable stage 3 cancer, which is also an early breast. We can consider early breast cancer. But after that, after stage 3A, then 3B, then 4A, 4B, then we have to consider for the neoadjuvant chemotherapy or palliative chemotherapy. This is the NCCN guidelines so far as the staging is concerned. Now we have taken the patient to the point where we have clinically staged him or her, and she is prepared for the further treatment. Stages, these are the clinical staging. Stage 2, 3. In the stage 3, with the N0 is stage 2B. Thank you very much. I think this will be sufficient. So far, the diagnosis of the multidisciplinary approach to the early breast cancer is answered.
Thank you, Dr. Kaul. I think in a nutshell, because of the elaborate topic he was given, he has given a good, total in a nutshell, the true picture, how the patient has to be handled. And especially it will be very useful for the postgraduate students who are dealing in the early
Yeah, exactly.
How to examine the patient, what to do, and when to do what type of test.
Yes.
So thank you so much, Dr. Kaul.
Thank you, ma'am. Thank you very much.